coupling mesh which is placed and fixation is rarely required by tackers. So it's economical for patients, but there are particular indications for ET periostopas. Normally, we do hernias which are ventral hernias which are more than or equal to 4 centimeters. So less than 4 centimeters, there are other options. IPOM plus even now is the most commonly performed laparoscopic ventral hernia repair. So everybody should know how to do an IPOM. These are advanced laparoscopic procedures. So the three keys to unlock the steps of ET periostopas. One thing is the crossover. The first thing is the crossover. Second is the posterior closure. And third is the anterior closure. So crossover, what is a crossover? Crossover is nothing but it is developing connection. So you develop connection from one space to the other space. You develop connection from the left retroractor space to the right retroractor space by crossing a bridge called falciform ligament. Okay, that is actually a crossover. It is developing connection between two spaces is crossover. So what are the steps of crossover? So once you place the pores, here you have to identify the seam. Seam is nothing but the junction of the left posterior rectus sheath with the rectus muscle. So then you can see the left hand is depressing the left posterior rectus sheath because it becomes taut. So then you incise the left posterior rectus sheath just 5 mm from junction to linea alba. If you incise it more, what will happen is there won't be much posterior rectus sheath left for the closure. So these are one of the reasons where you end up doing a transverse abdominis release even for small defects because you don't get enough purchase of posterior rectus sheath peritoneal complex. So once you have done that, you stay on the roof. So you stay on the roof. You stay on the roof, see that you don't breathe the linea alba, and all this fat has to come down. Normally, I incise the posterior rectus sheath up to the hernial defect. What happens is, once you incise it, the pneumoperitoneum itself will help in creation of this space. You can see that the pneumo is helping. So take the left hand there, just depress the fat. It is the falciform ligament pad of fat. Okay, just depress it down. Don't be in a hurry to do a crossover because we don't want any linear breach. Even if the linear breach occurs, there's nothing to get panic. You have to reconstruct it. That's it. So once you do that, I actually define it. Actually, the posterior rectus sheath. I again depress the fat till where I have cut the posterior rectus sheath. So now you can see that. So you can see one thing how to identify the linea alba. One thing is the crisscross fibers of linea alba. Is the whitish crisscross fibers. Second, you can see the contraction now. You can see the twitchings of the rectus muscle. You can see. So that then you know that the rectus muscle is below that because of the twitchings. You now with this you know that is the posterior rectus sheath of the right side. Then you incise the posterior rectus sheath of the right side. When you are incising it, you should ask your camera surgeon to zoom out. So once the camera surgeon zoomed out, you know where to exactly incise the right posterior rectus sheath. Otherwise, if the camera surgeon comes very close, then you cut it parallel to it, then you lose the posterior rectus sheath. So that is the transverse abdominis muscle on the floor. That's the rectus muscle. So now we have developed connection between the left retroractor space and the right retroractor space. And in between what the falciform ligament you have depressed, it is called as the preperitoneal space. So by depressing the preperitoneal space, you have developed a connection between the left retroractor space and the right retroractor space. That is the simple crossover. So the all principles of ET periostopas is you should not cross the semilunar line. If you want to cross the semilunar line, you have to do a transverse abdominis release. Only then you can enter the space which is beyond the semilunar line. Otherwise, linear seminitis injury is one of the most dreaded complications of all these ET, TAR surgeries. So all the ports are also placed within the linear seminitis. So that is the crossover. Now there are certain challenges. Suppose if the patient has an upper abdominal scar, there is high chance of linear breach and you may encounter early pneumoperitoneum. Yesterday you have seen during the entry itself there was a pneumoperitoneum. So first everybody should know how to avoid problems first. Second, how to identify the problems. And third, how to manage it intraoperatively. So most of the mistakes, if they are managed intraoperatively, they are more dreaded compared to any postoperative complications. So sometimes the falciform ligament can be short, very short falciform ligament, 5 cm. Then when you cut the posterior rectus sheath, immediately there will be pneumoperitoneum. In case divarication of recti, very wide divarication of recti, you tend to have, yesterday the patient had a wide divarication of recti. So what I did was I went inside the abdomen, then I identified the posterior rectus sheath, then I cut the posterior rectus sheath. So mistakes can happen because of early pneumoperitoneum during entry or during port placements or during crossover. Linea alba breach. So once you cut the posterior rectus sheath, you have to see the vertical muscle fibers of the rectus muscle. If you see anything white, that means that you have breathed the linea alba. You are into the subcutaneous tissue. So if you do a crossover very higher up, instead of cutting the posterior rectus sheath, seeing the rectus muscle, you see the transverse abdominis muscle. So it's not only the muscle, the direction of the muscle fibers are also important. Third thing is the bowel injury. So now this is one technique where very rarely you can make mistakes in the crossover. Just see this video. You place the port there, 10 mm port, you place there. Now again you make one more incision in the right hypochondrium. You place one more port. So this is for the beginners. If you do this, there is no chance that you can miss by doing a crossover. Now you have two ports. Now you create the left retractor space by telescopic dissection. Either you can use a 0 degree or a 30 degree. I am comfortable using a 30 degree for the space creation as well as for the entire procedure. So now you know that you have created the left retractor space. This is a very reproducible technique, safe technique. Those who want to start ET peritopus, for initial cases you can do it, because once you start doing mistakes in the crossover, then you come low down on confidence. Then you cannot try also doing ET. Now you created the retractor space on the right side now, right? So you have placed two ports, 10 mm ports. You have created space on both sides. So already you have created space. On the right retractor space is created. The left retractor space is also created. Then you place an additional 5 mm port under vision. Now you can see this video. Now we cut the left posterior rectus sheath. Is cut. Then that port which you have placed in the right hypochondrium already, that acts like a GPS. You can see here. You can redirect it. That acts like a, so that's moving. Then you know that that's the posterior rectus sheath. So that port is slightly moving. Then you incise it over there. So this is a very safe technique where, no, I don't think so anybody can make mistakes in this crossover. Then you incise it. Wherever the port is there, you incise it over the port. You see the rectus muscle. So this is one of the very reproducible way to do a crossover and not to have mistakes in your initial learning curve. Now posterior closure. Posterior closure, what I mean is the PRF, that is the posterior rectus sheath, or the peritoneum. So why you have to close the posterior rectus sheath? When you have to close? Now why you have to close? Initially what I was doing was, yesterday you have seen, I was closing the posterior rectus sheath, start above from the xiphoid downwards, including the posterior rectus sheath which was covering the falciform ligament also. So I was under the belief that it will form a flat surface for the mesh to be placed, and it may improve the abdominal contour of the patient, and it may prevent postoperative bulges, and it can also form a better barrier for the mesh. You can see in this video. So this was a simple PDS, that's Maxon by Maxon. It has got better visualization because it was green in color. I was closing this, the entire posterior rectus sheath from xiphoid downwards, completely. But after a paper by Argadaz recently 3 months back, so he actually proved that the postoperative bulges are actually due to deficient anterior rectus sheath closure rather than the posterior rectus sheath. So the falciform ligament closure, the posterior rectus sheath closure above the falciform ligament is not required. Only if you close the deficient posterior rectus sheath or peritoneum, that defect, that is enough. Now when I used to close that, now I have started closing that. If the falciform ligament is very thin, the posterior rectus sheath above the falciform, or if there are multiple rents on the falciform ligament, or if the peritoneum is extremely thin, because any increase in intra-abdominal pressure, patient may have some small buttonholes and there is every chance of bowel herniation. So during that time only I close the posterior rectus sheath from the falciform ligament downwards. But believe me, whatever you do, it has to be tension-free repair. The posterior rectus sheath peritoneal complex has to be a tension-free repair, which is the benchmark of hernia surgery. You should not be closed under tension. Now, main thing is closure without tension. So reduce the pneumoperitoneum pressure to 6 or 8 mm mercury. Either you can close it vertically, you can close it transverse, or you can close it oblique. But believe me, tension-free closure is the benchmark. With what? You can either close with V-lock, you can use a barb suture, you can use a 2-0 Maxon or a PDS for posterior closure. This is the indigenous Maxon knot. Yesterday I have demonstrated that you make a eye outside itself extracorporeally. It will act like a barb suture. So you can place one of the initial knotting can be prevented. Now, suppose if you cannot close, you have done a TAR also. Suppose if you cannot close, you have done a TAR, you do a transverse abdominis release. In spite of doing a transverse abdominis release, both sides, suppose if you are unable to close the posterior rectus sheath, One of the tricks what you can do is you can take the omentum, you take the omental patch, take the omentum and suture the edges of the omentum to the posterior rectus sheath PRS complex. So in this way, instead of a bowel adhesions, you can have a omentum there. The omentum is bridging the gap on the two edges of the posterior rectus sheath peritoneum. So this is one of the techniques what you can do. You can always use a vicryl mesh, but in this case, what I am showing, what I have used it, I have used a tie mesh. I think this was the first time which I have done using a omental patch. Recently, in upper abdomen where the peritoneum is very thin, I was unable to close it because of the thin peritoneum. Then I used the falciform ligament as a patch. So you can have all these things. The vascularized falciform ligament. Here I have placed a tie mesh. Tie mesh is a mesh which can be placed both extraperitoneally as well as intraperitoneally. Then above that I have placed the prolink mesh. The area where I have buttressed it with omentum, I have placed a tie mesh. Then above that you can place the polypropylene mesh. Now everybody should know how to avoid a TAR. How to avoid a TAR. So we should not end up doing a TAR for smaller defect. It's not justified. So transverse abdominal release is required for a bigger defect or whenever unable to close. So what happens is, see, first we have to define the seam, all the fibrofatty tissue. Here you see, you cut all the fibrofatty tissue. First, initially you cut, don't directly cut the posterior rectus sheath. Cut all the fibrofatty tissues. Then you define the exact junction of the PRS with the linea alba or with the rectus muscle. So you can see now, first I am clearing all the fibrofatty tissue. Don't be in a hurry. As soon as you see the posterior rectus sheath, don't cut the posterior rectus sheath. Then you will have difficulty in closure of the posterior rectus sheath. This is one of the cause where people end up doing a TAR. See that the fibrofatty tissue was from there. If I would have cut it 5 mm below that, I would have had deficient posterior rectus sheath for closure. So once I clear the fibrofatty tissue, then you insert it 5 mm below that. So you should all know how to avoid a TAR. See here you can see there is a small falciform ligament. Because of the space which you have created, the pneumoperitoneum is not hampering the preperitoneal space. So start concentrating. Another thing is, see this, again on the right side you divide PRS close to the linea alba. Don't go that. That's the reason I was telling the camera person should zoom out. So that you know exactly when to cut the right posterior rectus sheath. So cut it, see this is the divarication of rectus. You cut the PRS closer to the linea alba. That's 5 mm, 3 mm rather than breaching the linea alba. You can see that that's the divarication of recti. Now, adhesiolysis is a part of a abdominal wall reconstruction procedure because if there is any adhesions posteriorly in the peritoneum and PRS complex, the PRS peritoneal complex won't come down. So this is another technique. You can see that is a 14 cm defect where I have not done a TAR. So what to do is preserve the sac technique. See, that's a huge hernia. I have used a part of the sac. Sac is the peritoneum which has herniated. This you have seen, I have cut both the PRS and till the inferior margin of the defect. Now, meticulously you have to separate the sac, you see that. You use this sac for posterior closure. So you should ask your assistant to put a pressure, gentle pressure. There should be a good coordination between you and the assistant. Now you create the space between the sac and the subcutaneous tissue. We should not injure the skin here. Either you can use the harmonic shears, you can use the hook, but I have kept it at low. Correct? You see that a part of the sac. And this sac, you have to maintain in continuity with the posterior rectus sheath. That's very important. This is called as the preserve the sac technique. This is one of the techniques where you can prevent TAR or a transverse abdominal release even in a huge or large hernias. See that the sac continuity is maintained with the posterior rectus sheath. And part of the sac which is left on the near the defect that you can use for to close the anterior. See that the preserved sac. That is for anterior closure. See that it is coming without tension. So I have not done a transverse abdominal release. So use the sac which you have preserved to close it posteriorly. In that way, this is one of the tips to prevent a TAR. Another thing is you can see that you have cut it, you have done a crossover. Another technique is a preserve the bridge technique. So you have a bridge of peritoneum between the two posterior rectus sheath. So you prevent, there's the peritoneum. See that there's a bridge of peritoneum sometimes you find between the two posterior rectus sheath. You try to preserve this peritoneum so that even in a large defect the peritoneum posteriorly is enough. So in these are some of the techniques where you can prevent a TAR and just do ETP reustopas even in the larger defects. That is the bridge of peritoneum between the two pairs. Now you can see here. So basically it's a tension-free closure which you have to aim it. See, to be honest with you, every complex hernia doesn't require a transverse abdominis release. Because of the complexity of transverse abdominis release, everybody wants to become a Tarzan, but what I feel is understanding the tar zone is important rather than being a Tarzan. So abdominal wall reconstruction procedure is a part of a field called herniology. So everybody should know how to do an IPOM plus, because the only savior, if you have any complications in a abdominal wall reconstructive procedure, let it be ETP, rheumatomas or a TAR, is an IPOM. So everybody should know how to do an IPOM. So what I feel is you should know how to preserve the sac. In that way you can preserve the TAR. You should know how to do a TAR. It doesn't mean that you should do in every patient. Patient should earn the TAR and surgeon should learn TAR, how to do a TAR. Now coming to anterior closure. Anterior closure is not only the defect closure, you have to reconstruct the divarication of recti, you have to reconstruct the linea alba also. So it is both reconstruction of the abdominal wall so that the function of the abdominal wall is restored. So it is both reconstruction as well as restoration of the function. Reconstruction of the abdominal wall and restoration of the function of the abdominal wall. Here you can see that that's the linea alba. I have used, since I train people in hernia, in all these abdominal reconstructive procedure, the many surgeons who come to me from distinct places, so who may not have an access to the barb suture. So here you can see that I am using a Prolene or a PDS for all these things. I have used a PDS for this. So main thing is there is no shortcut for suturing. Everybody should know how to suture. So this is only the 3-port technique. This is a novel technique by me. I use only 3 ports for ETP rheumatomas.
I think another 1 minute.
Yes, sir, it's done. So anterior reconstruction is very, very important compared to posterior reconstruction to prevent a preoperative, postoperative bulges as well as recurrence of hernia. Here you can see that that's the simple PDS which you have used, and here is a barb suture. Now divarication of recti. Divarication of recti, you have to repair it, otherwise the patient continues to have bulge in the postoperative period. Here you can use, this is a PBT, which is a barb suture by Covidin. So divarication of recti, you have to repair. It's the rooftop suturing. You have to master this when you want to do this, all this reconstructive procedure. Very, very important to have a good skill of intracorporeal suturing on the roof. Now coming to anterior closure, defect closure is a must. All divarication of recti need to be reconstructed. Linea alba has to be reconstructed because linea alba is the central tendon of the abdominal wall. Just like what you have a spine behind is the linea alba. So it has to be reconstructed to restore the abdominal wall function, to improve the abdominal wall function. Now this is my team. You have seen Dr. Marina yesterday, who was the camera surgeon for me. We have one more surgeon called as Dr. Amol. This is my team working together. So thank you all for this opportunity. Thank you.